I'm just going to give you a brief introduction to Melinda. So Melinda grew up in Australia. She's a Brisbane girl, studied at the University of Queensland and then trained in paediatric neurology at Sydney Kids Hospital and the Hospital for Sick Kids over in Canada. She has a subspecialty interest in paediatric epilepsy, which is always good in a doctor that's interested in tuberous sclerosis, and also in the difficulties faced by children with TSC, especially in those affected by difficult to control seizures. So Melinda and Claire have spliced up neurology, and they're going to talk a little bit each. We'll hear from both of them and have some questions in between. Thanks, Melinda.
So, just make sure I've got the right direction. So basically, first of all, I'm going to talk about the structural abnormalities and explain some of them. I must say that quite a lot of what I've said, or will be saying, will overlap with David and be hopefully complementary. So if you had any difficulty or were getting overwhelmed with some of that information, don't worry, you're about to hear it in a slightly different version, but the same sort of, some of the same areas. And then we're going to look at some of the functional abnormalities, particularly those ones that are very complex but not necessarily anatomical, such as epilepsy, the problems with cognition, the problems with autism, and psychiatric problems, just as an overview. And then we're going to look at some of the therapeutic priorities and briefly our surveillance that we recommend. So again, this is something that David's explained very well for you, that there's two main genes that we're worried about that we can identify, and we do find mutations in the majority, but there is a small group that don't have mutations available. And again, David has mentioned that the TSC1 tends to be a milder form, but there's a considerable overlap and you can have extremes in both ends of TSC1 and TSC2. So we won't need to go over that much in detail. I've put this one up as a sort of more simplified version of some of the pathways that you may have come across or may have had discussions about or heard about with mTOR. So the reason I wanted to use this one, and it'll come up a couple of times, is that we have lots of, as you've heard from David, lots of interest in this pathway for therapeutics. So basically, if you consider this the edge of the neuron, the neurological cell that does a lot of our work for us in our brain, there's some growth factors at the top, and I don't know if you recall David's slide showing multiple pathways, so this is simplified, but there's some multiple pathways lead into these ones, and these are our tuberous sclerosis genes here, our TS genes here, and they hold back or regulate mTOR, and mTOR's function when it's let free, or when it's positively reinforced, is to cause cell growth, proliferation, growth of blood cells, and just general growth and proliferation of cells in general. So this is the area that we're looking at particularly. And we consider these to be tumour suppressor genes that negatively regulate. So by negatively regulate, we mean put the brakes on. So some of the neurological complications, these are the most common in TS and cause the most degree of impairment, and it's obviously what a lot of people are concerned about with this diagnosis. The genes themselves can cause abnormal brain cell differentiation, so that means rather than focusing and forming into a nice neuron that will communicate well with the other cells, they can form bizarre, sometimes giant neurons that don't communicate well and don't function well in the brain, so they don't differentiate the way they're meant to. They also, without TSC modulating these pathways, they can form in very disorganized layers. So in our brain, we have very clear layers of cells, and in the tubers and the abnormal areas in TS, they're all mixed up and there's no clear layering, and they're all, rather than talking to each other in layers, they're sending off different messages all in the wrong direction. And as you can imagine, that can lead to chaos in that little area and then hypes things up and can lead to seizures and other interruption of pathways throughout the brain, causing the other problems that are associated with the brain. So some of the classical structural brain findings, which I'm just going to show you some pictures of, are the cortical tubers, and that's what I've just explained then, that they're the sort of disorganized, muddled up, not communicating well, not communicating with the other parts of the brain well, little lumps. The subependymal nodules, which tend to be not so much the neurons, they're what we call the white matter and the astrocytes. So they're not actually the thinking cells so much, they're more some of the pathway cells, but they form little lumps. And sometimes when their lumps get bigger, they can form into these subependymal giant cell astrocytomas. So this is a picture you can see here, some tubers, just to show you. I'm sure some of you have seen multiple pictures of these before, but I just wanted to show you what we are talking about. And these are some of the little subependymal nodules just along the edges of the ventricles, and this is the fluid-filled space in the brain. And in this picture, this is the fluid-filled space here, and this is a SIGA, so that these little lumps here have got bigger. And once it's more than 1 centimetre, we call it a SIGA. And the concern, as David has mentioned also, is that there's fluid draining through here. That's a very important way that the brain cycles its fluid and keeps everything metabolically active. And if those drainage areas get blocked, which can happen actually quite quickly, it's not always a gradual process, unfortunately. If they get blocked, then it can lead to quite serious problems with the blockage of the fluid swelling up, causing pressure on the brain. And that's another example there. Oh, sorry, my little pointer's gone, there it is. So this was from a textbook, but I also wanted to show you that we have many patients, so just to say that our patients look very similar to the textbooks. It's not sort of a disease where it's not clear. This is one of my little patients. She's only about 2 at this particular scan, and you can see it's a bit fuzzy, but there's lots of tubers all around, and particularly up in this area. And she has some little nodules as well, subependymal nodules. So then if we go on to the SIGAs, which only occur in about 15%, but is what we do a lot of the monitoring for because of their concern of their rapid growth causing hydrocephalus, which is when you get the fluid blockage. So they do grow slowly usually, and they can arise from pre-existing nodules. Yeah, that's probably better with the lights, thanks. And most commonly, unfortunately for us, they do often commonly grow near that outlet. So if they grew right up into the corners of the ventricles, they wouldn't necessarily cause a problem. The problem is because they grow where the fluid tends to drain out, and that's why they can be mechanically such a problem. And not to be alarmist, but they can grow suddenly and they can cause obstruction, and if untreated, could be fatal, which is why we keep making such a fuss about these particular lesions. They do occur predominantly in the pediatric age group and tend to slow their growth in early adulthood. So, this is something that we're thinking about for the everolimus and the other therapies. Do we need to keep going into adulthood? Maybe, and information's coming out, maybe we just need to get them into the early adulthood and then perhaps the growth will slow naturally. So that's, looking at our treatment options. But they don't respond to traditional chemotherapy or radiotherapy. At the moment, up until recently, the established treatment has been to monitor them periodically, and we'll discuss that a little bit more, and to resect them if they show growth or definitely if they're showing signs of increased intracranial pressure. Occasionally, a child or a patient may even need a surgical shunt to help drain the fluid if the fluid's not draining. But the surgery is complicated. It's a very difficult location deep in the brain. You can have complications from the surgery even when it's successful. And you can get problems where there's incomplete resection and the tumour regrows, and a few years later you're back where you started from. And then have to think about repeat resection. And David mentioned these statues, but I've got the picture for you. So Easter Island, so named because it was discovered on an Easter Sunday by a Dutch explorer, but was already populated by the Rapa Nui people, so otherwise known as Rapa Nui. And the rapamycin was a compound found in a soil bacteria, actually, that they originally thought might be an antifungal, and then they realised it had immunosuppressant properties. We're using it for transplant medicine, and in the process of that, realised that it actually had effect on growth and could reduce the size of some tumours. And from that pathway, we've discovered, well, not we, very clever people have discovered the mTOR pathway and how it affects growth and how we can suppress the growth, therefore, through the mTOR pathway. So mTOR inhibitors, mammalian to target of rapamycin, that stands for. So mTOR is involved in a whole lot of different processes, but the one that we're most looking at for this particular condition is the cellular growth and proliferation. But it does also regulate cell survival and cell death. So in our bodies, a lot of the time there are cells that the body has decided that it doesn't require anymore, or they're getting too excessive, and it just automatically programs cell death, and that happens all the time, skin in all different places, and it's all very well regulated. But that can also get out of control if you don't have the programmed cell death and those cells keep multiplying rather than stopping their function. So the mutations can allow this pathway to act abnormally and to be hyperactive, basically. And this little pathway again, where's my pointer? So now just to point out that this is where we're looking at. So normally our normally functioning TS genes would be having a regulatory effect on mTOR, and what we're hoping to do is replicate that to some degree with these medications. Of course, the problem is that these are very finely tuned, and they have a whole lot of other pathways leading into them to tell them when to switch on, when to switch off, when to switch on a little bit, when to switch off a little bit more, whereas with our medications, we're basically on or off to some degree. So that's a concern, at least theoretically so far. It hasn't been a clinical concern so far, but we don't have the fine control that the human brain has, of course. It's just too complex an organism for us to replicate just with medications. But there is a lot of hope that these are using this pathway we can impact and restore that tumour suppressant signal that the genes have lost. So in SIGAs, and this has been mentioned also by David, there's a phase 3 trial has been completed. It was multi-centre using sites all around the world, including Australia, and randomised, placebo-controlled, very well-structured study. And this is great because this is what we need in medicine. We need evidence that is sound and has been really well thought out, that we can put to funders and other people to say, this does work, we have the evidence, let's go on and get on to doing it. So basically, just to show one of the graphs from the study, that this was the placebo. Nobody improved with placebo. And 35% had a 50% or more reduction, and that's sort of their cutoff for saying this is definitely clinically efficacious. There was more than that had some effect, but not everybody responded. So there is still, unfortunately, a group who don't necessarily respond, but clearly it's a great help for the majority or for the group who do. So these are just a few cases to show, and just these ones were from some of Franz's work where the SIGAs definitely shrunk after just a few months of therapy. Unfortunately, it does recur in some cases after therapy has been withdrawn, and that was what I was mentioning earlier. You can get control back, but how long do we need to treat? We don't really have the answer to that question yet. Another case showing significant reduction in size, and you can see this was actually already, this person was actually already starting to get problems with increased fluid because those spaces are bigger than they should be, but managed to shrink it down. And just to, we have some cases in New Zealand, so I thought I'd show you our local perspective. This is a case of mine who, a bit hard to see when you're not used to looking at these scans, but this was the size of the SIGA here, and then within 3 months of therapy, it had basically come down to this size, and fortunately has stayed that size for at least 2 years. This is a child who had had to have multiple surgical procedures before everolimus was available, and it kept regrowing. So this was, getting to the point where we weren't able to offer a lot of other therapies other than repeated surgery, and with each surgery there's more risk of complications. So this has been really helpful because they've managed to control the size of this tumour and stop this child having any further symptoms from the fluid pressure for at least 2 years. She's actually an older child now, and so we're hoping to continue the everolimus therapy into her early adulthood and then see if we can stop it and what happens with recurrence. For the surgery, it had to come down through the frontal lobe, yes, yeah, to split down that way. This is the problem, that these grow right down deep, and so it is a difficult operation. And so, clearly every time, if you have to do that on more than one occasion, it's a significant burden to the child. So the potential limitations, just to try and keep a balanced view, because I know it's very exciting, but we do have to sort of keep in mind other aspects of it. The side effects in general, however, have been reasonably mild. Things like ulceration of the mouth and some minor problems with infection around the mouth, but also we do know that it is an immunosuppressant, so it can allow other infections to take hold that we're not used to having in I shouldn't keep saying children, in patients. So far, most of the studies that have had data on this, which have been used in SIGAs, and so have been actually reasonably getting on towards longer term, haven't shown very major side effects. There is this theoretical risk that because we're doing this constant bombardment of the mTOR pathway, that we could set up a negative feedback loop rather than the fine-tuned regulation that the genes would naturally do. But I don't think there's been any actual reports of that being a clinical problem yet with more aggressive tumours. So now I was just going to move on from the sort of structural tumour burden or burden of these structural problems to the more functional burden, which is clearly a big issue as well. So first of all, with epilepsy, this is one of the most common neurological problems and can be one of the most disabling. And it does affect a very high proportion, up to 90% of patients with TS. The majority do present within the first year, and as you've heard, we're really trying to focus on identifying the seizures as early as possible and getting onto aggressive treatment as early as possible. And our big concern with tuberous sclerosis and in epilepsy in children in general is infantile spasms. We know that that is something that, particularly if not treated or if difficult to treat, because sometimes it doesn't matter how hard you treat, it's very difficult to get control, but we know that that has a really significant impact on long-term cognitive function and long-term epilepsy if you can't get early control. Treatment, to some extent, remains disappointing because of the poor response overall to anti-epileptic medication, taking it as a big group. So there's some people who are on one drug and they've had a great response and they don't have seizures anymore, and that's great. That's what we would love to have for everybody. If you have to have epilepsy, to be able to be treated with one drug and stay on one drug. But unfortunately, there's a lot of patients who try multiple drugs, sometimes try combinations of drugs, move back and forth between drugs, and we still struggle with seizure control, even when their seizures have been identified very early in life, and even when we've tried from the very beginning to get control. So vigabatrin is a very well-established treatment in tuberous sclerosis, and it's certainly first line for infantile spasms, and that's appreciated and put into action in most places. There is support now for use of vigabatrin in early onset seizures, not just infantile spasms, which is coming through. If you have focal seizures in a very young infant, there's now growing support that vigabatrin should be considered early. But we do need to consider that it's not a completely safe drug either. There is a problem with the side effect of retinal toxicity, which can cause some reduction in your peripheral vision. This has been a bigger problem in adults than it has been in children, but children are also very hard to study, so that the percentage of children affected can be quite variable in various reports. It could be as low as 10%, but it could be high as 30 to 40%. It's sort of coming down towards the lower end of the range, but often you would need to do what's called an ERG, which is an electrical study under anaesthetic, to even study if it's causing toxicity. So that's another burden if you're having to use this therapy. So just to say that we know these therapies are available, and we're trying to always do that balance between risk of side effects, risk of seizures. In something like infantile spasms, it's a clear question that infantile spasms are a terrible seizure syndrome. We need to do whatever we can to stop those. And some of the other epilepsies, or other types of epilepsy in TSC, if you can get control with another agent, particularly in an older child, we tend to use the traditional agents first, and if we get control with that, that's good, because we don't want to necessarily use these other drugs that have risks. So this was just to show you, talking about infantile spasms, this is what a normal 6-month-old baby's EEG would look like, which is the brain patterns, just to give you an idea of why we all make such a fuss about infantile spasms, really. So this is just nice little regular lines that go along, just 4 or 5 little beats per second, blip, 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 in a nice orderly fashion. Whereas if a child has hypsarrhythmia, which is the EEG pattern we see with infantile spasms, it looks like that. And even from the back of the room, you can see that your brain, to be that chaotic, you're not going to be able to develop, you're not going to be able to make clear messages and communicate with the cells around the brain. And if that network continues to be that chaotic for a long period, you can see how this can interrupt your development and interrupt how your brain's ever going to make clear messages and your cognition develop. So then we're moving, if you're having problem with your first-line therapies, onto second-line therapies, and we try to be very rational, combination if necessary, but aiming for monotherapy, and then trying to work out if you do need a combination, what is the best combination, considering side effects, considering previous responses, considering the way the drugs actually work, the mechanism, maybe having some complementary, one that works on this type of channel in the brain, one that works on a different type of channel, and maybe together they can have a better effect than having two that work on the same channel. And some non-medical options, which I won't talk about now because Claire's going to talk about those in just a little while. So, of course, the big question, which David brought up, and I'm sure many of you would like to know, is there a role for mTOR inhibitors, the rapamycin, the everolimus group, in epilepsy? And there's a lot of interest and very promising information coming, but it is still coming. But I'll present what we have so far. So there are some animal studies that were very promising initially, showing also, as well as some seizure control, some evidence perhaps of learning deficits improved. And we're talking about a rat in a maze, so that's a very different question than a human in society, or some people may not think it's that different, but there are some hopeful things in the animal studies. So the first prospective trial, happens to be in children, but it was phase 2 data, and this is by the Franz Kruger group that David referenced before as well, has been completed in just a small group of 20 children, and it did show that everolimus can reduce seizure frequency, with 12 out of the 20 children treated for 12 weeks having a 50% or more reduction in seizures. So for medical literature, that's often what the cutoff is, 50% or more reduction. Obviously, what we'd really like to see is seizure freedom, but there were a small number in this group that were actually seizure-free as well. And I know Sydney's done a group of, I think it was 9 children where 3 or 4 became seizure-free as well. So this isn't the seizure-free group, this is just to show you the reduction in seizure frequency from baseline, about 45 seizures a day, so a very intractable group, and how it went down over, this is only over 12 weeks though, so it's a very short time span. But interesting and promising And clearly there's some other studies ongoing now that everyone's getting very interested in seeing the results when that's available. Just to put a little bit of a but on it, it is still a small sample size with only a short follow-up, so 20 children, 12 weeks. And there's some animal studies that have suggested that if you have everolimus all the time, it may affect your brain injury repair. That's still being looked into. We need to do human studies looking at how these drugs interact, so we have a better understanding of how they work with other drugs. And also, we still don't know long-term the safety concerns as far as if you're using a drug that suppresses your immune system long-term, does that change your malignancy risk and your cancer risk for other cancers later on? And how long do we treat, and all those questions, which may take a long time to work out, but it's all being looked into. So far, the findings have not been duplicated, but the only other studies were really the studies of SIGA, which were larger numbers, but the baseline was different. In the SIGA studies, a lot of the patients didn't have epilepsy. So if you don't have epilepsy and you have the drug and you still don't have epilepsy, you're saying there wasn't any change. But obviously so it wasn't set up to look for epilepsy. So, trying to look at those studies, it doesn't tell you the answer for epilepsy because that's not what they were looking for, and it's not what we can hope to base our data on. So short-term studies, very hopeful, and that's where we're really up to at the moment. So just a quick look at some of the learning and behaviour issues that affect children and adults with TS. About half have some degree of cognitive impairment, and I really like David's slide showing you those peaks. There is a bimodal peak with some who have done terribly from a cognitive point of view. And then there's the other peak, which, as you saw, is just a little bit shifted to the left, so with quite a big proportion still in the normal range. But in that normal range, we also have to remember you can still have specific learning deficits, and this is why we really try to access neuropsychological assessment, particularly in the older children as they're entering higher grades of schooling. They may have one specific area that they struggle with, and if we can identify that and let the teachers know about that, that can be really helpful for education. Some correlation with your gene mutation, but also there's some correlation with the tuber load, so a lot of tubers in the brain on an MRI scan does implicate you to have more problems with your cognition, not always, but does implicate it, and the location with the temporal lobe and autism being associated. There's also this other spectrum of behavioural and psychiatric disorders, which I can't give you solutions for, but we know that there's a lot of attention on those and a lot of behavioural inputs trying to help with those areas. Particularly just looking at autism, for those who haven't got a good understanding of what this is, it's a brain disorder that really affects how a person can interact and how they can communicate and how they respond to our social interaction, which is such an important part of day-to-day life for everybody. And the incidence is unfortunately quite high in TS, one of the highest incidents for a single condition. And we expect that's because of all this abnormal wiring and the balance being upset between excitation and inhibition, so the positives and the negatives not being in their usual balance. But we know there's also an association, as David inferred, with early onset seizures, particularly if they're not well controlled early onset. That can have an increased risk of autism, particularly infantile spasms. And also the temporal lobes are very important to our emotional reactivity and how we regulate our emotions. So if there's a big tuber lobe in the temporal lobes, that can be a poor prognostic sign for these problems. Great. Okay, so I was going to leave you some question time, which I will be about 15 minutes worth. So this was just a cascade trying to show you that mTOR affects all these different areas in the brain. I don't know how well you can read that, but it's to do with the shape and the way the brain cells get together, how the pathways around them communicate, how the chemicals communicate, and how the proteins work. And all of these can impact on cognition, susceptibility to autism, and susceptibility to epilepsy. So they're all interacted. It's not that you have epilepsy on one side and autism on another. They're all to do with these disconnections and poor regulation of your pathways. So in the future, we have mTORs pretty much established now as an option for SIGAs. It's still, in some cases, if it's a very accessible lesion, we have used mTORs as a short-term therapy to reduce the size, make it more accessible, and then remove the tumour, because then the child is not subjected to a life or a very long period of everolimus. So there's different combinations of using it. It's not just surgery or everolimus. You can use the two as a rationalised way of using it. Encouraging, but as yet unconfirmed data in epilepsy. Some basic science data for cognition, and the mTOR's exciting, but we need to be cautious and not have unrealistic expectations, but we're hopeful. David did talk a bit about this already. The monitoring for the SIGAs, we do MRI brains. depending on what they look like, every 1 to 3 years, and some of the other options there. For epilepsy, we obtain an EEG in all known or suspected seizures and consider those medications, vigabatrin for spasms. Epilepsy surgery is an option Claire's going to talk about, and looking for other neuropsychiatric disorders. The main thing I wanted to stress here was trying to access neuropsychological assessment for education planning, because that can be really helpful and something that should be available in most regions. So in conclusion, significant complications in the brain. We have this evolving treatment of the mTOR inhibitors that is causing us a lot of hope, to have a lot of hope for the future, but just trying to keep that balance of looking for evidence, looking for safety, and waiting for ongoing research to give us a better idea of their role. And then I was just going to leave it open for questions for 10, 15 minutes.
We have the microphone, so we are recording. The idea of questions isn't that you get to ask a question that you'd ask your doctor in a consult, so a little bit more general. Hopefully, Melinda, are you able to stay into lunch a little bit?
Oh, just a little
bit. A little bit?
Yeah.
All right. So I guess I didn't really say it in the opening, but the idea that what you learned today is something to take back to your own or your child's doctors as well. So, and we are recording, so please use the microphone, and if you've asked something and you really don't want it to be kept on the recording, let me know, but it will be a lot easier if it can be kept. All right. Does anyone have any questions?
Hi, I'm Helen from Hamilton. My husband Brian, we've got a 17-year-old daughter with tuberous sclerosis, and we're in that really tricky stage of, teenage years anyway, and we've noticed some behavioural changes in her, and it's, when do you start thinking maybe we've noticed an increase in seizures recently after having some very good control. Mm-hmm. When do we start sort of saying maybe this is more than just teenage rebellion or teenage acting out, and put our foot down with the doctors that maybe we need to be delving deeper? She does have a SIGA.
And it's being monitored?
Yes, she had an MRI in December and they said that it didn't appear to have grown. Okay. But we were unaware until this year that she had one. We'd never been told before. Uh-huh. So that came as a bit of a shock. In some ways, I'm glad we didn't know. But
and it may, I don't know the individual circumstances, but it may have been that it just got to that size. I don't know, but and
then hasn't grown again. So,
yep.
And she had been having regular CT scans up until she was about 10, and then they decided that there's that thing of how much do you screen and scan, and what the safety implications of that, and leaving well enough alone. So
and having to have anaesthetics for scans and things like that.
Yes, and so balance. Exactly. And I can't say that we have had. I mean, we feel we've had very good clinical care overall. We're in that lovely transition phase where everyone I talk to, transition to adulthood, is going, what transition? And so we're having to take on more of that role that perhaps our paediatrician did before. And I'm just wondering, when do we start sort of saying maybe we've been told we're going to have to wait to see a neurologist until February, but the school have now come to us and said, we can see some changes and we have concerns. Do you think I should be?
I think if she's had good seizure control before,
yes,
and you're seeing more and more seizures, and it's particularly if it's a building up picture, then I think it does need to be reassessed to see, has she grown out of the medications? Are the medications no longer working for her? And if she hasn't had an EEG in the last few years, that might be helpful as well to see compared to previous. Yes. Is it a different picture now? Is it, because these tubers, I didn't go into this, and I don't want to take Claire's thunder, but the tubers are definitely implicated in the epilepsy, and they can change over time. There can be one tuber at one age that's the main problem, and you can either quieten that down with medications or potentially surgery, but it might be a few years later it's a different tuber and a different seizure type. So I think it is important to try and characterise, are the seizures the same, and if they're different, and if they're changing in frequency, something has changed. The other thing, just to be, and I did have it on the slide, but I forgot to point it out, is to make sure there's no other reason, like she's not developing renal problems or some other way to be systemically unwell that could impact on her seizures.
Yes. We had, hearing about anxiety and depression, that's the first we've sort of thought about it.
Yep.
And now we're wondering whether we need to be looking into that too, because there's certainly some anxiety, which again we've put down to typical teenage stuff, but maybe this is the time to be a wee bit delve a little deeper.
No, I think so.
Yeah.
might be a question at the back, Claire.
Sorry.
Back.
Oh, sorry. I'm looking straight past.
My daughter's on vigabatrin and has been on it for 3 years. How long can children stay on it for? Because we've noticed a slight change in her seizure type. And they're talking about adding a third drug into the vigabatrin, and she's not well treated. Is it something that she can stay on for a long time, or?
Yes,
not?
you can stay on it for a long time as long as you're aware of and considering the implications of the retinal toxicity.
Yeah.
And it is a peripheral field restriction. It's not saying that children are going to go blind, but it's always a balance. You know, if it's helpful for seizure control, it's probably better to have seizure control and even say definitely lose that and, you know, function with some restriction. That's what you've got to start to balance. But if it's not helpful for seizure control and its efficacy is run out despite adequate doses, and you've got to make sure she's getting the adequate dose for her size and weight, then the risk may be too big to continue it. So it's that balance of the risk versus the efficacy of the treatment on the seizures.
Yeah, no, cool, thank you.
That's right.
Hi. I was wondering if there's any chance, or does it ever happen that New Zealanders are involved in clinical trials?
It does. We did actually, I trained with John Lawson. He was a year or two ahead of me. And so we did look into that possibility, but at the time for the SIGA trial, the child had to be in Sydney for 3 months, and most candidates couldn't afford to maintain themselves in Sydney for 3 months straight. So we don't have quite a big enough population that someone like Novartis is going to come to us and base it here, but sometimes there is an option to try and join into the Australian arms of the trials. But for that particular study, you needed to be at least located where the trial was. So yes, there is, with logistic implications.
Just to say there, Matthew, our 24-year-old, was trial for vigabatrin and topiramate in New Zealand. Mm-hmm. So when they were first brought in, we were on the trial of that.
Yeah, so it's an example where we could join in. So maybe we should hand over to Claire.
So Dr. Claire Spooner trained in paediatrics in New Zealand and then neurology in Melbourne, completing her fellowship at the Royal Children's Hospital, working with Dr. Simon Harvey, who sees many TSC patients that are part of our broader Australasian tuberous sclerosis community. She has a focus on epilepsy surgery, and particular evaluation and surgery for infants and children with TSC, and that's what she's going to talk to us about today. What happens when the medications don't work?
Alrighty. Well, thank you very much for inviting me to speak. And I appreciate I stand between you all and lunch, so hopefully I'll keep you awake and entertained for that short space. So I'm going to sort of follow on from Melinda and David. Obviously, we always repeat what everyone else has said, just so that we really drum it home. And really focusing on tuberous sclerosis and the epilepsy side of things, and particularly my task, Melinda's covered the medical management, and I'm sort of going to speak about when the standard and traditional treatment doesn't work. So seizures occur in 60 to 92% of patients, and as David mentioned, sometimes an individual has gone lifelong without knowing that they have tuberous sclerosis, and certainly haven't had epilepsy. So the first time they are aware of that is when they present with their child who is having more difficulties with their condition, and particularly epilepsy. So despite the tuberous sclerosis causing lots of focal abnormalities on the brain, so little localised lesions as Melinda showed you in the scans, seizures can either be focal or they can be apparently generalised, so the whole brain appearing to seize at one time. They're often, unfortunately, refractory to standard medication. And we know that uncontrolled seizures during early childhood are associated with this more sort of the bigger syndrome. It's not just, epilepsy isn't just about the seizures themselves, it's about the effect and the impact it has on learning and development and behaviour. And it's not to say that the seizures are the only cause of that. I think that's really important. Some individuals will have developmental difficulties, learning impairment, and even autism, even if their epilepsy is well controlled. So it certainly impacts significantly, and we feel that it's something that we really focus and target on because it's potentially something that we can intervene in to improve somebody's overall outcome. So we do focus on that, but because the brain is abnormal in the way it's formed, children can and adults can have these difficulties even when their epilepsy is relatively well controlled. So I think I've just covered this. So we're aware that the refractory seizure disorders can progress to what we call an epileptic encephalopathy. So when some individuals have seizures, it's just a seizure arising from that area of the brain, but sometimes the brain can take on a life of its own, and the epilepsy can add to an impairment. So the epilepsy activity causes overall development and difficulties over and above the sort of the pathological or the structural abnormality that's there. So it's this, you've got a problem that could equally be contributing to learning difficulties, then you have the epilepsy on top, and it has a sort of more generalised and greater effect than the epilepsy itself. And this typically happens in a large number of epilepsy conditions, so it's not something that's seen in tuberous sclerosis alone. It's very much more common in very young children for this to happen, and particularly in infants in tuberous sclerosis are at high risk of this condition where the epilepsy can have a greater impact on their brain development. And so knowing that leads us to a belief that we can actually intervene. So I might just switch on to the slide. So what we often see is that there's a tuber perhaps in one area of the brain which is causing the epilepsy focus, but there's a greater area of disturbance of brain activity period sort of surrounding that tuber, which is causing a degree of impact. And for some individuals, their abnormalities may be localised just to that tuber, and they'll have their seizure, but otherwise they manage to function reasonably well. Other people have a greater disturbance and they might have a bit more learning difficulty. Other people, even though they have activity coming from what we believe is a single tuber, their epileptic activity takes on the whole of the brain and they have much greater impact. And we sort of don't fully understand how it goes from a single tuber, structural abnormality here, to affecting this entire brain as sort of a much, much greater network within the brain. And one of the sort of hypotheses is that the rest of the brain is actually trying to fix this problem that's happening locally. And so the rest of the brain's saying dampen down and sort of charging up, and it sort of buzzes to try and dampen this abnormal response that's happening locally. And then after doing this for a long time, sort of months to years, it suddenly becomes abnormal itself and starts having seizures. So you can actually set up seizures in other parts of the brain which are structurally normal. And in particular in tuberous sclerosis, one of the reasons that this is even increasingly difficult is many people don't just have one tuber, they have 3, 4, 5, 6, plus tubers. And so for some individuals, it could be one tuber that's actually driving the whole process. Other tubers might have been silent if this tuber wasn't so problematic, and they would have been okay, but this one sort of gets this one going. And another individual, actually, they've got multiple tubers that are very problematic, and they're all individually cascading this network that sort of is overflowing. And so that's kind of the process that we're trying to deal with, trying to find out which of the tubers are really, really problematic and try and focus on those. So not only do we aim to stop the clinical seizures, we want to interrupt this sort of whole global network to hopefully improve the general disturbance in brain function. So initial treatment, as Melinda has mentioned, is always initiated with anti-epileptic medications. But what's the response, the likelihood of responding to that medication? In some people it's very high, in some people it's very poor. And so what options do we have if those medications don't work? So this is sort of not applicable to tuberous sclerosis in itself. This is looking at all comers with epilepsy and their response to anti-epileptic medication. So if you have placed on your first medication, your chance of responding is about 47%. If you put on your second medication, your chance of responding to that medication is an additional 13%. By the time you get down to your third or multiple drugs, chance of responding to anything else drops to about 1 to 4%. So once you've failed 3 or 4 drugs, it's just inherent that your epilepsy is incredibly difficult to treat, and regardless of what magic anti-epileptic drug, the chance of responding is very, very low, which is obviously very disappointing. You have to remember that if your child or you as an individual are in that 1%, that's great. So it's always worth continuing. There are lots of medications and you could still be in that 1%, so it's not worth giving up, but it is worth being rational about what is your next best option, and that's what I want to focus on. So what are our options when we feel that medications are less likely to be effective? And I really want to focus on epilepsy surgery because that's mine and Melinda's passion to a degree. Melinda's already spoken about mTOR inhibitors, and I'm going to briefly talk about ketogenic diet, vagal nerve stimulation, mention corpus callosotomy, but I haven't focused on that to a degree. So epilepsy surgery is where we identify an area of the brain that's abnormal, is responsible for the seizures, and we can go in and operate on that area, taking out hopefully the entire abnormality and without causing harm. So obviously if you have an abnormality which sits right over hand movement and you have very perfectly good hand movement, it would be something that we would be very loath to go in and take that area of brain out, because we'd be replacing the seizures with somebody that couldn't use their hand. So it would take away the function of their hand. So it's always a balance in terms of, can we do the surgery with very, very little risk in terms of causing any further problems versus causing, just changing one problem for another. And sometimes we're in a difficult situation where the epilepsy is so bad, sometimes we're prepared to make a compromise and take a small surgical morbidity, I guess. So traditionally what we've looked at and what people have studied for epilepsy surgery, and it's been performed for almost a century now, so it's not a new thing. Epilepsy surgery has been performed before we had fancy imaging, before we had EEG technology, so it was done purely based on what somebody was doing with their seizure. People knew that had to be coming from a certain area of the brain, they went in and operated and fixed people. So we've fine-tuned that a lot, and I think we get much, much better results because of our techniques in terms of imaging and EEG techniques. But what we like to find is, the ideal, the easy surgical candidate is someone that has a single seizure, that it's obviously coming from one area of the brain. When we look on the scan, the area of the brain that we think is involved in the seizure matches where the abnormality is. And when we do the EEG, we confirm that that's indeed where the seizure starts from. So all the ducks line up and we go, this is easy. That's definitely the cause of the seizures. We'll take it out and the person will be cured. And we if it's as simple as that, we can offer an 80% cure rate for that person's epilepsy. So what's required in terms of undergoing surgical evaluation? Somebody comes into hospital, and some of you will have had this procedure done once, twice, 5, 6, 7 times maybe. They come in, they're hooked up, and we monitor them for up to a week, sometimes longer, depending on how many seizures they're having. And sometimes to provoke the seizures, we have to drop medication, not normally in children with tuberous sclerosis. They're normally obliging, and it's the only time we want children to have seizures is when they're in hospital and we're trying to capture them. But we can do things to bring them on. We can keep children up very late or keep adults up very late, provoke them with various means. So that helps us. We capture the seizure, we can look at that on the EEG, we watch what they do. And we can also use other techniques. So when they're actually having a seizure, sometimes we inject through a drip in the arm a radioactive dye, which goes to where the blood flow is going. So when you're having a seizure, that part of the brain requires more blood flow. And so we can do this sort of labelling of the blood, and it sort of gravitates to where the seizure is active, and we can then do a scan, and that shows us where the seizure is arising from. And similarly, we have other techniques in terms of radiology over and above MRI scanning, a technique called a PET scanner, where we look at the glucose metabolism. So our brain's very active and uses glucose as a primary fuel. And so when we pop you on the scanner, we should look that the whole of the brain should be using glucose. And individuals with an abnormality of their brain, that area that's perhaps more prone to seizures doesn't use glucose as much. And it shows an area of abnormality on the scanner, so it helps us identify which areas of the brain are potentially more problematic for the epilepsy. So this is a result of a child that's had a PET scan, and this is actually probably before a seizure. So you can see this area is down, this is a PET scan, that's why. So this is, so you can see the whole of the brain is utilising glucose. It's all bright orange. This area here is not using glucose very much, and so it's low, and this is an area of abnormality. And here, this is a SPECT scan. So this is the individual when they're just resting, they're not having a seizure. You can see that there's something wrong with this part of the brain. It's not lighting up as much. And then they have their seizure, and suddenly it lights up like a golf, glowing, whoops. And that tells us that that's exactly where the seizure is coming from. So many individuals with tuberous sclerosis do have a single seizure type and a single tuber when we look at them on imaging, and it's very easy to take them through and identify exactly where their seizure is coming from and are able to offer surgery. However, many individuals with very difficult epilepsy don't have a single seizure type. They have lots of seizures, so they may be, one moment they're steering, another moment they're having jerking, another moment their head's turning one way, sometimes the head's turning the other way, which would suggest that their seizures are coming from lots of different areas of the brain. And children with having spasms, the children tend to do this, and there's no focal, there's no sort of, it's not on the left, it's not on the right, it seems to be involving the whole brain all at once. So how do we know where those seizures are coming from? And so those individuals with those sort of seizure stories tend to be haven't historically been considered to be ideal surgical candidates, but they are, and they can certainly have successful surgery, and we evaluate children like that regularly. So over the past decade, we have demonstrated that it is possible to achieve good outcomes in offering surgery for these people. So this is some examples of seizures that are captured. So this is an individual, and you can see there's lots of tubers, some here on the right, on the left. And when we're monitoring this patient here, they're having the EEG, as Melinda shows, they're all labelled, so we know each little wiggly line corresponds to a little dot. If you've ever had an EEG, so this corresponds to a dot on the brain. And so this is the right side of the brain, the left side of the brain, the right side of the brain, the left side of the brain. And so you can see this is coming from the left frontal region. You can see there's an disturbance of activity here, and that corresponds to this tuber here. Whereas this seizure, probably an hour later, is coming from the other side of the brain, and it's coming from that tuber there. So it's kind of like working up, someone monitoring a patient. Can
you explain where you're seeing tubers?
Oh yeah, it's pretty. So the tuber, the white, see, you can see this white sort of brighter spot.
Oh, I see.
Yeah, and here again you can sort of see just in there. It's a bit hard because the lighting's not perfect for it. So it's where the brain structurally looks abnormal. And in some individuals it's not a really defined tuber. Sometimes you can just get wispy lines. So that's from that area there, and from the sort of more extensive, there's quite a few tubers all coalescing here together. Okay, so this is sort of like having 6 patients being monitored simultaneously, and that's the way you sort of think about it. What you want to do is fix each seizure type to help them with their epilepsy. And here again, so this is the same patient, and they've had that area removed and that area removed, and this was their EEG just at rest, and this is their EEG after surgery. Again, another patient, she's got seizures coming from 3 different locations, from that little spot there, this little spot, this larger spot here, and this one at the back. And so for each seizure type, she had different manifestation, and the parents were really excellent. They could pick the 3 different seizure types. They sort of listed them as ABC. It was steering with some eye blinking, steering alone, and jerking, and they just, they knew that the 3 different seizure types were quite independent. And this is just showing the interictal EEG of another child, and shows a very active area here over the right frontal region. And we did a SPECT scan with this child having a seizure, and we identified 3 areas that lit up over the right frontal, further here at the back. But we were deciding whether we needed to take that tuber and that tuber out, and the SPECT scan showed us that we really needed to take this one, but we could leave this posterior one, which meant that we could take these 2 in a single operation, but our craniotomy didn't need to, the cut in the skull didn't need to extend back as far as this, which would have just complicated surgery somewhat. We knew it wasn't involved, so we could leave it behind. But here's a case of a child with no obvious, it's not coming from one area of the brain. This is a EEG pattern which we would expect to be associated with very poor development. It's very chaotic. This is a child that's clearly having a spasm. The whole brain's involved. And luckily in this child, they didn't have many tubers. They had one big one and one little one further back. And so what we could do with that child, not really knowing where it was coming from, is we could actually just take the tuber and rendered her seizure free, which was great. So in the small case example, we were able to improve the major disabling seizures in all of the children. They still had some seizures. I'm not saying that we dramatically got everyone to seizure freedom. All had improved behaviour and attention. And it just shows you that you can remove a single tuber and interrupt this very chaotic network here, which is one of our goals, as well as improving the epilepsy itself. So moving on, Melinda's touched on the mTOR inhibitor, so I won't spend too much on that. I guess the difficulty we have with epilepsy over and above treating seizures is that the seizures are something that are actively growing. The tubers in the brain are fixed. They don't grow over time. They're a structural abnormality that has occurred very early in development, and so it's less clear what this dysregulated pattern of growth is having ongoing. We know the tuber itself is epileptogenic, as proven by the fact that we can actually take the tuber out and the epilepsy settles down. So how sort of down the track, how we interfere with the mTOR pathway can affect the control of the epilepsy is slightly less clear, and perhaps that's why some individuals aren't getting seizure freedom on the everolimus, because it's the actual structure that is present that is causing the ongoing epilepsy network. But however, it does bring us, whilst there is this encouraging work by Franz's group, which Melinda's talked about, there's also some other examples and conditions which are very similar to tuberous sclerosis and are involved in the same pathway. So this is a very small study in a condition called polyhydramnios megalencephaly with severe epilepsy, PMSE, and it's associated with a genetic defect which is just up above the tuberous sclerosis gene, so it's a different gene. But they're kind of like a severe TS, and they typically have very refractory and frequent seizures, up to 180, 200 a day. And what they did in this very small group is they had five toddlers treated, and by the time that they treated them on the everolimus, and by the time they were on their maintenance phase, of these 5 children, only one had a single seizure in a year. So this is sort of opening the can of, the possibility as to whether you actually treat prior to the seizure burden. So, it was sort of suggesting that maybe when you're diagnosed with tuberous sclerosis, that you actually start treating with everolimus at that point. This is very emerging research, and it's not something that I would be prepared to do at this moment in terms of data, but I guess this is what we're sort of looking at, where the future is going with individuals with TS. So the ketogenic diet is another treatment, leaving surgery behind. Ketogenic diet is a diet that's high in fat, low in carbohydrate and protein, and we know that it can be very effective for treating epilepsy, and I think it's a good treatment to talk about in a family conference, because the ketogenic diet came about from family observation. So I think it was a parent of a child who had epilepsy who noted that whenever their child got sick and was hot and wouldn't eat, that actually their terrible epilepsy settled for a while, and that was sort of occurred over time, and it was realised that when they were starved and unwell, they went into this ketotic state, and for some reason that state was acting as a seizure treatment, and this has now been adopted and is mainstream in terms of treatments that we use. I say globally, we personally in Auckland and New Zealand have had very much difficulty using this treatment because it hasn't been funded. But so basically the brain and liver metabolize fat as a source of energy instead of glucose, and seizure control improves. And in terms of looking at data, so 36% of children had more than a 50% reduction. So when you've tried and failed 3 or 4 drugs, and your chance of responding to any further medication is sort of maybe in the order of 4%, thinking about the ketogenic diet offers you a greater chance of hope, and maybe 50% reduction in 40% of individuals is certainly something to consider. Obviously the ketogenic diet is not like taking a medication in the morning and a medication at night. It's changing the whole way that you and potentially your family eats, because everything has to be measured. You need to have the exact amount of carbohydrate, and so all of you, if you're doing it very strictly, every single meal has to be weighed, measured, counted, and that can be very challenging at the very beginning of starting this diet. When you've been on it a year or 2, people can start doing it in their sleep, and they know, they have a rather restricted set of meal plans and they roll them over. But so 7% had an even greater, than 50% and 90% reduction, almost seizure freedom. So it does have good results. And we don't really, other than the fact that we use ketones and fat as a source of energy, it's not fully understood how that actually works in terms of controlling seizures. But just in the past 12 to 18 months, there has been some studies looking at that the ketogenic diet may work through the mTOR pathway. So it may act as, the ketones may act as an inhibitor like everolimus. And there's been, looking at that data that I was showing you before with the 40%, with a 50% reduction, was of all people with refractory epilepsy. And most studies, unfortunately, do look at all comers with epilepsy, so it's a big mixed group of people. There's a little bit of work looking just in individuals with tuberous sclerosis. A case series here of 12 children, 11 had a greater than 50% reduction, and 8 of those had a greater than 90%. So pretty promising data. Again, it's small numbers. The more you do, the more the numbers will reduce, unfortunately. And you only have to shift somebody from, when you've got a small number, from one group not doing well to another, and your percentages drop quite significantly just with statistics. So the smaller the number you have, if you happen to have a few that do well, make it look very promising. So that we certainly have people that don't respond to the ketogenic diet as well. The vagal nerve stimulator, obviously another treatment that we can provide. And just going back to the ketogenic diet, we have struggled for years to get this. This is a treatment that has been available and has been given in a very small number of people in New Zealand for decades. We essentially got our funding cut probably about 5-7 years ago. And we have been pushing very hard to get that funding back. And we are very excited because we have got funding for 2015 and are currently in the process of employing our own dietitian. So a job interview is going for that at the moment. I'm not suggesting that we're suddenly going to be able to provide this diet to 100 people, but it is on the up again, which is great news. So vagal nerve stimulator, this is like a pacemaker for the brain. So you put this little disc in, and wires wrap around the vagus nerve and send impulses up, and that can prevent seizures. So again, this is not looking at TS per se, but in all comers with difficult to control epilepsy and have this pacemaker put in, on average, and again these numbers depending on the paper that you read vary a little bit, but on average, a very small number becomes seizure free, about 5 to 7%. In terms of getting a greater than 50% reduction, you're sort of looking around about 40 to 60%, depending on the paper that you look. So again, when things are difficult, this is a potential option. Again, I have to say sadly that we don't have funding for this at the moment. We did, the DHB let us do a pilot case of 10 cases last year because they didn't believe the international literature. I'm not sure why New Zealand patients would be any different to an Australian or an American patient. Having said that, there's no public funding for vagal nerve stimulators in Australia either. And that's partly some of our difficulty in getting it funded here, because our funders do look to what's happening in Australia sometimes, and if they're not funding it, they're less likely to fund it here. There is a large work being done looking at the cost effectiveness of this device, and hopefully we're going to get new data being produced in the next year or so, which we may be able to take back to our planners and funders and try and prove that this is a treatment that is effective in many. So in the vagal nerve stimulator, again, there's very small studies looking at groups of children and adults with tuberous sclerosis alone. And this study showed, I think, 11 patients. 11 patients. And in one, they had a greater than 80% seizure reduction. In 60%, they had a 50 to 75% reduction. So that's certainly a good control. Again, the difficulty is small numbers. So tuberous sclerosis can be very challenging. It's important to consider once the medication appears to be failing that there are some other options. They can have excellent outcomes in some. Unfortunately, it's not a cure-all for everybody, but it's about looking at what other options are there and trying to access everything that is possible to improve an individual's epilepsy and overall development. Okay. questions.
Who would like to ask a question?
My question is, what about Sativex?
Okay, Sativex. So Sativex, for those that don't know, is, and Melinda might want to stand up with me, is a cannabinoid. So there's been a lot of talk and medical interest in medical marijuana. And there is a lot of anecdotal evidence that marijuana can improve seizures, along with a number of other conditions, particularly neurological conditions. So marijuana obviously contains a psychoactive component, which we call THC, and there's also a non-psychoactive component, so the bit that doesn't cause hallucinations and the social high, and that's called cannabidiol, or the cannabinoid component of it. And so obviously we don't want to be giving a medication to anyone, particularly children, that is going to make them high. We know that marijuana is very addictive and probably more addictive in children than in adults. It does have effects on the brain. We know that the brain's not fully developed until at least 25. And so there are significant risks in giving marijuana to a developing brain. It has particular risks in terms of cognition and memory. Having said that, when you're in a very difficult position and you see on the internet and on media that somebody's been having more than 50 seizures a day and is taking a substance and they're having none, you've got to weigh up those benefits and risks. And there is no product that is pure in cannabidiol and cannabinoid. There is a drug that is currently being investigated at the moment and is under clinical trial called Epidiolex, and that will be a couple of years away before we actually get scientific evidence that may be effective in seizures. So what do we have in the absence of that? We have illegal homegrown marijuana, and there is a plant called Charlotte's Web, which is available in the US, and some people have got that specific breed of marijuana that is illegal to bring into New Zealand. It's illegal to grow and it's illegal to distribute, but some individuals are doing that and making an oil out of it and treating their children. The reason that it's this particular breed is a brand of plant is that it's low in the THC component, and so it was actually initially, Melinda's done a lot of work on this, it's really called the hippie's disappointment, because it was basically a plant that didn't really give the effect that people wanted, but it's potentially effective in terms of seizure control. And so the drug companies have gone on to try and sort of make this CBD pure in terms of a proper pharmaceutical, but as I said, it's going to be years away. What we have in New Zealand over and above an illegal option is a drug called Sativex, which is a nasal spray, and it's a mixed concentration of both the THC component and the non-active CBD component, which we want. It is available on Ministry of Health consent. It's really approved for use in multiple sclerosis. We are trying to put together an application to use it in very selected individuals with very, very difficult epilepsy, for which it seems reasonable to use that when we don't know greatly the benefits scientifically. We don't know the real risks of using it, but in some individuals who appear to be so poorly affected by their epilepsy, we feel that the risk balance may be there. It is not funded, so it would cost anywhere between, at best, $100 a month, but I think that would be like giving a drop of lolly water, up to about $1,000 a month to treat. And there is until there is more scientific evidence that is actually an effective treatment, I think that there would be a very slim chance that Pharmac would fund it. So it is there. We're currently actively engaging conversations with the Ministry of Health in terms of using it for epilepsy, but we're certainly not going to be supporting it for anyone that hasn't tried all the regular options that have been well studied in terms of their risks and benefits. Did that answer? Yeah. Helen?
Would you be able to explain sort of how you get to see a neurologist in New Zealand?
To see a neurologist? Okay. Yeah, so In general, I can't speak entirely for the South Island because I'm not entirely up to speed on their referral process. For Auckland, there are really only the neurologists that are based at Starship for a paediatric. This is paediatric speaking only, and referrals must come via a paediatrician. So people must be already linked into their GP paediatrician and then referred on. We don't have a direct referral process from GPs. If somebody was wanting access to a neurologist, then certainly a GP could call us, and within reason we may discuss that it would be appropriate for us to see, and we can work out a pathway for that. There are a few, there are 2 paediatric neurologists that work in private in New Zealand, one in the North Island, one in the South Island. But yeah, it really generally has to come via a paediatrician.
What about if you're in,
Yep,
you
I
know,
can move on.
other parts of the country?
So other parts, so from a paediatric point of view, the Starship neurologists, myself, Melinda, 3 of our colleagues, we visit all the peripheral centres. So we visit Northland, Tauranga, Napier, Gisborne, New Plymouth, and then the southern neurologists visit Palmerston North, Wellington, Christchurch, Otago, Blenheim. So we do satellite clinics, and we do them 3 to 4 times a year, and obviously if the need was such that somebody needed to be seen more quickly, then their DHB would fly them up to Auckland at the DHB's expense. From an adult perspective, there are many, many more adult neurologists, and they do, I believe, take GP referrals. So your GP can refer you through to a neurologist, and there are many in Auckland. There's about 12 adult neurologists working out of Auckland City Hospital, and there are many more adult neurologists scattered through the country, so they're not quite as a scarce resource as the paediatric neurologists, and there are many, many that work in private.
That's really helpful.
Do you have any literature on the diet, the ketogenic diet, that we could look at? And
yeah, there's. I mean, the original handbook, the John Hopkins handbook on the ketogenic diet, is what we recommend people to read. It's a reasonable novel, but it does cover pretty much everything, and it's not unmanageable to read. And I think in terms of the diet, it is going to start up very slowly. There are sort of other forms of the diet that aren't as strict as the ketogenic diet, which may be able to provide, potentially as good a seizure control. So that's the modified Atkins and a glucose, sort of just a low glycemic index, which is sort of what's promoted as being healthy for a large number of people. Will find that does improve seizures to a degree. So there are some nutritionists, dietitians in the community that can provide support, but if you are interested in the ketogenic diet, then it's best to sort of raise that with your neurologist, and our nurse specialist can provide resources.
And sorry, I've just got another question for Melinda that I didn't ask before. The neuropsych test for preschool children, how do we get that rolling?
Preschool? I'll just stand next to Claire so her microphone might pick it up. For preschool children, it does depend on to where you live and what the resources are where you live. Because there are neuropsychologists or psychologists who are capable of doing neuropsychological assessments in most reasonable sized towns. I particularly visit Tauranga and Whakatane, so Tauranga does have them. So it should be accessible, and in an ideal world we would do it prior to primary school, prior to secondary school, prior to...
Also, prior to primary school, the amount of testing you can do in preschool is relatively limited, and it's about 6 to 7 is when you can start doing a much more in-depth neuropsychometric testing though. So I mean, it's good to have it on the radar and know where your child's at preschool entry, because you want the resources there. But it's sort of by about 7 that the academic need starts to take
and they can
off,
do more
and they can do
complex testing. Yeah. So it's always a resource issue.
I always feel like I'm on a game show.
I just wanted to ask, I'm Hannah, I'm from Gisborne, and my little boy 5 has TS. At what stage do you decide that the medications are failing as such? His seizures, we're kind of thinking 2 or 3 a week. he would have to sleep off. That would affect his life. He also has kind of little spacey looking
point.
episodes that don't seem to affect his life. But they're kind of more at the moment, like more 1 a day, 2 a day sometimes. At what point do you think you're kind of muddling along and you think, well, this maybe could be better?
Yeah,
and we should try something else?
definitely
What's
at that
line
point.
that you get to where you think this isn't?
Yeah, so I
working?
think there is always a grey line. I think somebody that's having 1 or 2 seizures a year and it's not impacting on their general ability to function in any other way, obviously you're not going to be looking at other more extreme measures of management, because the risks of those treatments wouldn't outweigh the burden that the epilepsy is having. And I think where you sort of start to get a grey line is probably at the month mark. I think anything seizures under once a month, we would be looking at intervening, and sort of less frequently than monthly. I think it's sort of up to negotiation, but for some people, and particularly for adults, a seizure once a month or more, once every 2 months can still be a significant burden for them because they can't drive and it will interrupt in their work. So the differences in the impact on adults can sometimes, often in children we tolerate a higher burden because they're dependent anyway. But certainly I would, that example is a clear cut. That's not sort of something that I would question. That's more than what I would accept.
My name's Adrian. I was going to ask the same thing that you were about the neuro. Our son Matthew's 24. We only got him assessed when he was 22. So it hasn't been widely available. We've asked in years gone by and it was never done. But it's good now to, years later to get it done. The other thing is Matthew has been on, I think, nearly every anticonvulsant over his time, and it's almost like, he'd kind of grow out of one, and we put him on something else, and then that would work again, or else it's almost like you get your life, and you think, oh, okay, we'll try something else.
The honeymoon effect.
Yeah, and then we'd go on to something else. So he's now on to Pyramate and Tegretol, which he's been on for about 5 or 6 years now. But we've been through lots of combinations. So I think it's kind of don't give up on the one. There are other ones. And I think, is it a growth thing too? They change?
I think unfortunately the brain outsmarts the drugs and they become resistant. So you sort of produce a new drug and the brain's a bit sort of going, oh, this is new. I better be quiet and I won't seize. And then it's sort of, oh, yeah, I'm a bit sick of you, and I'll sort of, they get a bit resistant to the medication. Sometimes you can give them a holiday from the drug and withdraw it for a little while and then reintroduce it, but you get these periods where you have a bit of control for a few months, and then the brain works out a way to get around the medication.
Going back to surgery, I was lucky enough to meet Dr. Kate Riney when we lived in Brisbane, and she started doing a neurosurgery workup for us because my daughter Riley, who's 6, has never had her epilepsy well controlled, although her seizures are more focal, complex, partial. On coming back to New Zealand, when we were referred to a neurologist, they were told that because she wasn't having permanent brain activity on her EEG, it wouldn't be an option. So moving forward,
I would disagree. Unfortunately.
So how do you get to see the right neurologist? Because we currently are at Waikato. We actually have gone back to Brisbane,
right.
But unfortunately at the Mater Children's Hospital, we've just got a letter to say that you need private health insurance when they actually moved to the new hospital.
I mean, I think it's always difficult. You're always going to get different opinions, and I don't want to promise anything because it may depend on the actual individual data. But in terms of epilepsy surgery for children is performed in one centre, in my opinion, in New Zealand, and that is in Auckland. Nobody else does anything. So I think if you...
The other paediatric neurologists around the country agree with that.
Yeah. So that's not us creating it is a difficult thing to provide. It's very labour intensive and very resource intensive, and we just don't have the resources to provide it locally in every centre. So it is provided at Auckland, and so I think if you wanted a second opinion with regards to epilepsy surgery, then I think you'd specifically ask for that from your current paediatrician or neurologist, and they should feel comfortable referring on.
Okay, so we actually were signed off by this neurologist. So currently we don't have a neurologist. So I could actually ask for my paediatrician to directly refer me to someone like you guys.
Yeah, I mean, maybe we could talk
Okay, cool.
directly, because it just sounds a little unusual, that story.
Oh, we have another question.
Hi there.
Hey.
I'm just wondering, it might be a silly question, but is there any chance that the everolimus can actually cause seizures?
A lot of drugs, I'd sort of be cautious to say no, because many drugs, whilst we want them to be protective from seizures, can work. Even the medications that we use, some of the epilepsy medications can sometimes have a paradoxical effect and cause seizures. I'm not aware of everolimus causing seizures. I don't know in your work, David, whether you've ever seen it.
I only ask because our son has lots of nodules, and we were told he's very lucky he isn't having any seizures. And so he started everolimus for a seizure, and a couple of months into it, he started having seizures. So he's only been having them since starting the medication.
It's curious.
And he went for 7 or 8 years with nothing.
I mean, the easiest answer, I think, is to say it was possibly, has
Just
at risk of seizures and it's a chance. But, I think the longer we use things, maybe we will see a small,
because he's
number
been
that
on it
have
for
a
a while.
paradoxical effect.
Thank you.
Well, I wasn't really going to tackle that one because that's too hard. But I was just going to say, I mean, what it illustrates how complex it is. And you can't put all your eggs in one basket. You really have to look at everything. And you have to sort of come back to the beginning, or know your neurologist know the individual well. Things change. So what kind of appeared to be the situation at one time doesn't mean that's going to be the situation later. You then have to review the data, get some more information from maybe telemetry, etc., to then so there may be a surgical approach may be warranted at one stage, but then contraindicated at another. So I suppose that's the message. You can't just be in favour of a surgical approach. You can't just be in favour of a medical approach. You have to consider all options, and diet and vagal stimulation. And that is, you need to see an expert. And and as a parent, if you're getting one view and it's, you're kind of hearing about other potential views, I think somehow you have to try and fill the gap one way or another.
And it's always hard to challenge your physician, I think, sometimes. But in general, most paediatricians and neurologists go in a desire to help people. And I think it's unusual for someone not to want to be prepared to help. I think sometimes, no one likes to feel like they don't know everything. So sometimes people have a different way of if they don't understand or don't know enough, their defence can be to say, you don't know what you're talking about, and it's a way of just not taking it personally, because at the end of the day what you need to do is move forward and get the access that you need. So it's a matter of trying to work in a non-threatening way, and most paediatricians, I think, are pretty good. I think there's very few that struggle with that. Sometimes you have a little bit of a hiccup, but most of the time it can be worked through and maintain a good relationship.
Any more? There were some other hands earlier.
I'll just add one little thing to that. I must say, in the New Zealand setting, we do need paediatricians. So you need to have your paediatrician who knows you and is doing a lot of the role of, compared to a better resourced situation that some of the specialists might be doing. Not saying that you don't need the specialist, but you do need a paediatrician.
Hi, I'm Tam, Helen's husband. I just wanted to ask, hopefully good news that something has changed since... how old's Mac? 12, since 10 and 11 and a half years ago. And it's that relationship again between yourself as the clinician and the patient. But advising on the medication to take, is that something that you guys now are prepared to stand up and make, or, give the advice, as opposed to so like in our situation it was, there are 3 options, which one do you want? And of course our response was, well, we don't really know any of these 3 options. And that has changed, hopefully?
Well, I think we like to engage families, because some of the medications, there isn't a lot of difference between, we can't guarantee. I mean, clearly vigabatrin is ahead in terms of tuberous sclerosis for very early onset seizures. But once you've failed a couple of drugs, there's still 10, 15 medications that may be effective. And for some people, one medication and their side effect profile may be just absolutely abhorrent and they just don't want to touch it. And for others, that doesn't worry them. And individuals, it is a combined, I mean, we will always make the decision in the end if families don't want to, but we do try and give the family some autonomy in terms of a preference if we don't feel that there's a lot of difference between the medication. And because every individual family may say, well, actually, I don't like the sound of that, or I've had a family with bad experience with steroids, and I'm just a bit averse to that at the moment. Can we try this first? And so it's about making sure that you are aware, I guess, that there are options and that there's not necessarily clearly a lead. I think if we felt strongly that there was one medication that was going to be better, we will certainly would push it pretty hard and guide you. Yeah.
Informed consent, I suppose, where we're aiming more.
My understanding is that the consensus guidelines do now recommend vigabatrin as first-line treatment for infantile spasms.
Yes.
So in McGregor's case, if he was born today, I believe that the situation would be, let's try vigabatrin first.
Absolutely. Yeah.
So I don't know if Tam, if that's what...
I didn't realise that was the background to the question. No, definitely.
Yeah, that's in there.
Yeah.
But that's one of the few that's
One quick thing to that, and that is, Claire, I hope you still occasionally sit in the hallway to help people make these decisions. You know, sit on the floor with them, you know, knees up in front, and have a real personal conversation, because that's what makes the difference sometimes.
That's okay. Yeah, no, I'm still pretty flexible.
Or do we let the Willises ask their one? I was going to say one last question before lunch. All right, no one's challenging you, Helen. There you go.
I guess I do have a bee in a bonnet about identifying infantile spasms early as well. And I don't know, is there anything we can do to educate GPs and plunket nurses, particularly in our case, was the one that said, don't worry, babies make funny movements. You know, how do we get them identified quicker than 3 months?
In an audience like this, it's a common condition in a GP's world where they're dealing with heart disease and you know the chance that they see a child with infantile spasms can be low. I guess we're trying to improve epilepsy in general, and we've sort of developed a New Zealand League Against Epilepsy, for which we're trying to provide increased education globally in terms of paediatricians. So we just had our educational day for all paediatricians for young onset epilepsy, which we had a high focus on spasms, and we hope to do that.
80 paediatricians.
80 paediatricians, yeah. So by sort of doing those sorts of in-servicing more and certainly spreading that to the primary sector. It is hard because you can imagine for every neurologist there's 100 paediatricians, and for every 100 paediatricians there's 1,000 GPs, or possibly not that many. So it is hard to get very consistent messages out there. There are certain ways that, you know, articles that, you know, perhaps we could take more of a role in terms of our ever-growing role is to, you know, perhaps do some articles in the GP magazines, because our, you know, we sort of tend to educate the next layer down, and actually reaching out to that sort of more wider general community is hard. But I think that's part of hospital planning as well in terms of creating those networks.
Just to comment on that was myself and a lot of parents who, not necessarily TS parents, who were parents with Lennox-Gastaut children, and on our local epilepsy group, they set up an education program for teachers, teacher aides, and anyone who was interested. And we all had videos of our children with their seizures, you know, which everyone thinks is a bit odd, but not when you've got children. And that was a good teaching tool. So whether you could do something like that in your community, get the local epilepsy or autism or anyone who's, you know, to do that as a teaching, because that spreads out the word, you know, wider community of people actually seeing
There is a real push. The ministry have it on their agenda in terms of managing epilepsy in general, sort of in the community, and there is a task force currently looking at, trying to disseminate and ensure that there is really good guidelines for everybody. And the epilepsy, we have 2 epilepsy organisations, sort of support organisations in New Zealand. So there's Epilepsy New Zealand, and I'm going to be called out here, and the Epilepsy Foundation. And so we are trying to work together with both of those organisations to form a more cohesive network, because the difficulty is the more, and was the problem in Australia as well, the more sort of disparate groups that you have, sometimes it can actually work against you. Everyone's sort of doing their own thing in silos, and so the aim is to actually work more cohesively together and be able to disseminate this sort of information.